Hello, everyone, and welcome to the today's session of Recurrent Implantation Failure, brought to you by Apollo Fertility. To speak on this topic, we have Dr. Sangeeta Anand from Brookfield Center. She's our in-house fertility consultant, and to give a brief background about our doctor, she has done her MBBS MD into Obs and Gynae, and she's also done her fellowship into reproductive medicine. So she's one of the most renowned fertility specialists at our Brookfield Center here. So, ma'am, we are looking forward to hear from on this particular topic about recurrent implantation failure. So, this is quite a common thing nowadays in IVF and those cases. So, we are looking forward to hear from you, ma'am. It's all yours. Yeah, ma'am, we
Pritam.
can start now.
Yes. Hi everyone. Good evening. Can you hear all? This is Dr. Sangeeta Anand, consultant at Apollo Fertility, Brookfield, Bangalore. Today I would like to talk about recurrent implantation failure. Implantation failure is a really frustrating condition for the patient as well as for the doctor. Where is the problem? Reproductive failure can happen when there is a failure to conceive, when there is a repeated failure to establish implantation in a woman who is undergoing IVF, or it can present as a recurrent miscarriage, abortion in a woman who doesn't have any difficulty in conceiving. We should know that 30% of the pregnancies are lost at the pre implantation stage. Second, around 30% are lost after implantation, but before the lady misses her periods. Before she could detect that she is pregnant, she loses the pregnancy. That is, just the beta HCG comes positive and then it starts to fail. Third, 10% are lost after the missed periods. So, what is repeated IVF failure? Repeated IVF failure is different from an implantation failure. Implantation failure is a part of repeated IVF failure. So, there is a lot of confusion. How many attempts of IVF to tell as failures and how many embryos? Are there any avoidable causes for IVF failures? There is no universally accepted definition for recurrent implantation failure, despite many publications. In definition, it's a dynamic and depends upon the population which is being studied, as well as on the type and the quality of clinical practice. Implantation failure can be defined when there is a failure after 3 embryo transfers or on a total sum of more than 10 embryos transferred in multiple cycles. So, recurrent implantation failure is not the same as repeated IVF failure. Recurrent IVF failure is a failure to achieve a pregnancy after several IVF attempts, a common cause being a poor ovarian response or a poor result. Recurrent implantation failure is a subgroup in recurrent IVF failures. So, what is implantation rate? Implantation means the number of embryos which has produced ultrasound evidence of an intrauterine gestational sac per total number of embryos transferred inside the cavity. On an average, day 3 embryos gives 30% and day 5 embryos gives 40%. Is chemical pregnancy also considered implantation failure? Clinically, implantation failure refers to the failure of the embryo to reach up to the stage that it is recognizable by ultrasound. What are the common defendants? One is the egg and the embryo quality. Second is the uterine receptivity. Third one is the embryo transfer techniques. So, age is a very important factor. As we all know, women are born with certain millions of eggs, which keeps declining as women ages. Beyond 35 years and 38, definitely the chance of pregnancy declines because of the poor oocyte quality, which leads to aneuploid embryos. So, age is a very important single variable factor that affects the ART outcome. Not only the egg quality as well as the endometrial receptivity. Pregnancy depends on implantation of a developmentally competent embryo. For example, it can be like sowing some seeds into the soil. The soil is the endometrium or the uterine cavity, and the seed is the embryo. There should be a crosstalk between the embryo and the endometrium. to achieve a pregnancy. Maternal factors. The most common factors, as I said, the endometrial factors, uterine factors, obesity, thyroid, endometriosis, immunological causes. These are the common causes from the mother side. Embryo, the embryo quality, and the thick zona sometimes, or an inadequate culture condition, or a bad embryo transfer technique. So, going to a case when there is a repeated implantation failure, the doctor can get a lot of information from the previous cycle. What was the drugs used for stimulation? How many oocytes were retrieved? What was the method of fertilization? What was the fertilization rate? And what was the embryo quality? And which day of the cycle the embryo was transferred? And what was the age of the embryo, whether it's a day 3 or a day 5 embryo? And was the embryo transfer technique easy? So counseling should always precede the investigation process to ensure to understand the rationale, the potential benefit, and the cost implication of the proposed test. Preferably, there should be some information leaflets which can help the doctor to do the counseling process. So evidence-based investigation should include there should be a high-resolution ultrasound scan. If required, you have to do a hysteroscopy and screen for congenital and acquired thrombophilia condition. Other commonly performed investigations, but which have a weaker evidence like karyotype of the couple, laparoscopy when there is a doubt of endometriosis, or an endometrial biopsy. The role of immunological testing for natural killer cells and cytotoxicity is still controversial. Like anatomical uterine factors, like looking for a polyp or a myomectomy, adhesiolysis, or removing hydrosalpinx, doing a salpingectomy or a metroplasty, all these can improve the pregnancy chances when it comes to uterine factors. Now we have to search for a correctable pathology. When you look at the uterine cavity, up to 45% of patients with RIF, you can look for a correctable cause. Like as I said, there can be polyps in the cavity, or there can be adhesions, intrauterine adhesions, or a submucous fibroids, or there can be endometritis, chronic endometritis. All these can be corrected. So we have to look for correctable causes in the uterine cavity. Evidence in the absence of an identifiable pathology, there is evidence that performing hysteroscopy alone, even just a diagnostic hysteroscopy, can improve the likelihood of pregnancy in the subsequent cycle. Next, going to the uterine septum. Hysteroscopic septal resection can improve the reproductive outcome in infertile patient. Even a minor septum can improve. And if there is a history of septal resection or a metroplasty, then we can postpone by 1 or 2 months and then plan the embryo transfer. But after polypectomy, patients can undergo ovarian stimulation after polypectomy or even have an embryo transfer immediate cycle. Next, going to the fallopian tubes. A damaged fallopian tube becomes visible in scan. Many a times, mild swelling in the tubes are not visible. You just see some fluid in the endometrial cavity. This swollen fallopian tube is called hydrosalpinx. This swollen tube can have an impact on pregnancy. How does it affect? Either by mechanically flushing the embryos, preventing it from attachment, or it can have embryotoxic inflammatory chemicals which can prevent implantation, or it can alter the endometrial histology, and there can be a lack of expression of endometrial adhesion molecules called integrins, which are very important for implantation process. So there have been several studies which say that when there is a hydrosalpinx detected in scan, removing the or disconnecting the connection between the uterus and the fallopian tubes can improve the pregnancy rate by about 35 to 40%. So what are the option management? Either you can do a laparoscopic salpingectomy or you can do a proximal tubal occlusion. Just prevent the communication between the swollen tube and the uterine cavity. Bilateral salpingectomy can result in improved implantation as well as it can improve the pregnancy rate compared with controls who have hydrosalpinges. Improved pregnancy rates in patients who have had hydrosalpinx and who have had laparoscopic salpingectomy after experiencing recurrent implantation failure. There have been evidence to tell that when there is a repeated IVF implantation failure in patients who have hydrosalpinx After salpingectomy, the pregnancy rates have drastically improved. So, but sometimes doing a salpingectomy prior to stimulation is not advised. We always plan salpingectomy after the ovarian stimulation, especially in women with a diminished ovarian reserve. Either interruption of the uterotubal anatomy, patency, or a ultrasound guided drainage of the hydrosalpingo also can be recommended. Next, going to the thin endometrium. See, either a thick endometrium or a thin endometrium, both have an impact on implantation. Ideal number is between 7 to 11. Endometrium gives you adjuvants which can improve the endometrial thickness, which can improve the endometrial blood flow, like aspirin, sildenafil, endometrial coring or endometrial scratching, we say, and oral estrogens. And sometimes we do give intrauterine GCSF injection. Endometrial scratching or the coring before IVF. There is a mechanical, we do a mechanical manipulation was found to be associated with increased chance of deciduous formation in guinea pigs. So this endometrial scratching is usually done in the luteal phase of the previous cycle, or we can do even up to 5 days of the current cycle when you're planning the embryo transfer. So what they say that it releases some chemical process. In women with recurrent implantation failure, inducing a local injury into the endometrium in the cycle prior to the ovarian stimulation or during the embryo transfer cycle improves the pregnancy's chances drastically. It should be done in the luteal phase of the previous cycle or up to 5 days in the current cycle. And it should not be done in the cycle where you do the oocyte retrieval and when you're planning a fresh transfer. Next, the thin endometrium. Next, the thin where it seems difficult or impossible to make it grow. Endometrial thickness of 7 mm would define a normal endometrium. But if it is less than that, if it's difficult to grow, is refractory endometrium. One is the previous history of DNCs, miscarriage leading to DNCs, which can cause adhesion formation, or a previous myomectomy, previous history of partial ablation, or a radiotherapy, or chronic infection, chronic endometritis, or congenital uterine anomalies. All these can cause adhesions and it can lead to a refractory endometrium. So, ultrasound evidence of thick endometrium doesn't mean that it is receptive. Thickness, echogenicity, and Doppler assessment of the uterine and spiral artery flow are what the routine test we do to check whether the endometrium is ready for embryo transfer. The imaging techniques can provide some amount of information about the endometrial receptivity up to a certain stage, as pregnancies have been found maximum when the endometrial thickness is between 7 to 11. Endometrium lesser than 5 mm and above 11-13 mm are again or non-receptive. But molecular technologies will help us to further investigate and understand the endometrial receptivity, but still needs to be validated in a prospective trials. Again, hypoechogenic endometrium was more receptive than iso or hyperechogenic endometrium before HCG triggering. The proper triple line pattern has been found to give a better result. Is there any minimum thickness required to establish a clinical pregnancy after ERT? No, there is no agreement on the thickness. Ideal. What level is thin, what level is thick, nobody can tell. They have seen pregnancies at 5 mm and up to 15 mm pregnancies have been achieved. But a good triple line, triple layered, multi layered endometrium with a good blood flow has been found to give good results in IVF. Chronic endometritis. As I said, women, chronic endometritis can be either bacterial, parasite, or any viral infection. Women with chronic endometritis, they show altered uterine receptivity, and that explains the reason for recurrent implantation failure. So, when there is a repeated failure, even after putting a good quality embryos, if there is a failure, we need to check if there is any evidence of infection. In developing countries, the most common cause for chronic endometritis is tuberculosis, which has to be ruled out. Hysteroscopy is reliable in diagnosing chronic endometritis and it can assess the clinical effectiveness of the antibiotic therapy. micropolyps or small polyps, which are considered a reliable diagnostic sign of chronic endometritis, which can be seen in hysteroscopy. And histology, you see stroma of the micropolyps is characterized by accumulation of inflammatory cells, which is a feature of chronic endometritis. Now, how to manage refractory thin endometrium? As I said, we use adjuvants like aspirin, vitamin E, pentoxifylline, sildenafil, and we do surgical procedures like hysteroscopy, try to cut the adhesions and stem cells and GCSF, intrauterine GCSF injection. Most commonly used is low dose aspirin. Next is pentoxifylline. We give 800 milligram twice a day for 3 to 4 months prior to starting the treatment for FET, frozen embryo transfer. Next, going to other causes of recurrent implantation failure, there can be congenital or acquired thrombophilias or immunological causes. Thrombophilias are usually corrected with aspirin, low molecular weight heparin, and steroids. Immunological factors, we give intra lipid, intravenous immunoglobulin, and steroids. So, the uterine receptivity depends on the endometrial thickness and the lesions inside the uterine cavity as well as the immunological factors. More than 85% of immunological causes of recurrent implantation failure are autoimmune in origin. So primarily, we have to look for SLE, systemic lupus erythematosus, rheumatoid arthritis, Hashimoto's thyroiditis. All these are associated with increased levels of ANA, which in turn is related to recurrent implantation failure. Secondary or reactionary could be because of endometriosis. Women with endometriosis have a high levels of uterine natural killer cells in the endometrial cavity, which can lead to recurrent implantation failure. And 15% can be even idiopathic. Say for implantation immunotherapy, we usually, how does it work? It enhances the phospholipid production by the trophoblast, and it has an anti-thromboplastin effect and decreases the platelet adhesiveness. And intralipids reduce the natural killer cells. Immunoglobulins are very expensive but used in specific cases. Then prednisolone. Now, intralipid. Routine use of parenteral nutrition. Intralipid is a fat emulsion that was reported to suppress the abnormal natural killer cell cytotoxic activity in the peripheral natural killer cell for women with recurrent implantation, both in vitro and vivo has been suggested. So, this can be given in women with repeated implantation failure when there is a high uterine natural killer cell activity. Next, steroids. A meta-analysis of 13 RCTs found that there is no big evidence of routine use of steroids in women undergoing IVF. Even in RIF cases, there is no strong evidence to tell that aspirin as well as steroids gives a improvement. Next, screening for inherited and acquired thrombophilia condition. Is there any relationship help in ERT patient? Serum testing for congenital and acquired thrombophilias could be useful in identifying the patients who can benefit by giving low molecular weight heparin and aspirins. While empirical treatment with heparin is not justifiable, although it is recommended that patients diagnosed with RIF should be investigated for acquired as well as for hereditary thrombophilia. Now going to the embryonic factors. When there is a failure with a day 3 transfer, then we go for a day 5 transfer. When there is a thick zona after a frozen in a frozen embryo cycle, we do assisted hatching. Next, we can do a sequential transfer, or we can think of a co-culture system or a embryo glue. Now, when low ovarian reserve in a woman of advanced age has repeated implantation failure, we can think of oocyte factors. So, pre-implantation genetic testing. When there is a male factor contributing to infertility, EMC check the quality of the sperm before selecting it for is a rate limiting step in human reproduction. the quality of the embryo what we have transferred, the number of embryos we have transferred, what stage of development we have transferred, and what protocol was used. Instead of IVM, sometimes IVF, IVM can be an alternate in women with repeated IVF failure, especially in women who have PCOS. Is morphological grading sufficient? Embryonic interventions that can improve the IVF outcome. As I said, pre-implantation genetic testing and selecting the embryo for transfer. Next, going for a and blastocyst transfer. It is not suitable for all patients. Young patients who have a multiple eggs, who have a more number of day 3 embryos can be selected for blastocyst transfer. And need not every patient undergo blastocyst transfer, and the pregnancy rate seems to be almost same between a day 4 transfer and a day 5 transfer. Why blastocyst is more competent? Because there is activation of the embryonic genome that occurs at the 8 to 10 cell stage. That is a day 3 culture. So embryos that cleave after day 3 in culture, therefore, are no longer dependent on the maternal DNA RNA transcript and have made successful transition from the maternal to the embryonic genomic control. Is blastocyst transfer a successful treatment in patients with RIF? Live birth rate after fresh IVF is significantly higher with blastocyst transfer as compared to cleavage stage transfers. But recent study says that even day 4 gives the same results as day 5. Instead of culturing it outside the human body, some embryos behave well when you put it in day 4 stage. Next, going to assisted hatching. What is assisted hatching? It was noted that cleavage stage embryos with a thick, reduced zona thickness seem to have a good prognosis for implantation. So, we can do it mechanically by using a piezo micromanipulator or by laser. Assisted hatching was related to increased clinical pregnancy rate and multiple pregnancy rates in women with RIF. Assisted hatching slightly improves the clinical pregnancy rate, particularly in poor prognosis patients, including those who had a recurrent implantation failure, who had a previous poor quality embryos or advanced stage women more than 38 years, or women with endometriosis where you expect the zona to be thick. Next, going to the pre-implantation genetic testing. About the value support or does not support is still under debate. Next is embryo glue, hyaluron enriched embryo transfer medium, where this hyaluron gives a higher chance of implantation. Embryo glue, recent studies say that it does not improve the chances of subsequent pregnancy in refractory in IVF cases. There was a study in which 42 women embryo glue for 10 minutes prior to transfer inside the uterine cavity. In the control group, embryos were transferred to the conventional blastocyst culture medium. In patients with recurrent implantation failure, it was considered to be a very useful transfer medium. Again, the evidence suggests that clinical pregnancy rate and live birth rate with the use of functional concentration of embryo glue as an adherence compound in ART cycles have shown better cases of recurrent implantation failure in cases of recurrent implantation failure or sperm chromatin structural assay and sperm chromatin dispersion test. DNA fragmentation index of 50% has to be corrected in RAF patients. Next, going said, IMSI is a real-time method where sperms are selected before the microinjection takes place to identify the sperms that is devoid of surface vacuoles. The magnification with the regular ICSI is 400 times, whereas in IMSI, the magnification power increases to up to 6,000 times. So, the only confirmed indication for IMSI in recurrent implantation failure, while routine use of IVF is still not recommended. Next, going to the embryo transfer technique. How atraumatically the embryos were put inside the uterine cavity, how much comfortable the patient was during the procedure decides the pregnancy chances. There should be a prior mock embryo transfer so that the clinician is aware of the uterocervical length, whether the uterus is anteverted or retroverted, how is the cervix, what kind of catheter the doctor has to use, and how much is the distance. So the prior mock transfer helps to avoid difficult transfers many a times. And it should be done in a optimally full bladder, not too full bladder, and it should be done under ultrasound guidance. Sometimes there can be a better result with a sequential embryo transfer or a interval double embryo transfer. And frozen embryo transfers give a better result. Is FET cycles is an easy and good alternate? Yes. Vitrification is a boon, which an ultra rapid freezing method that keeps the biological and chromosomal integrity of the embryos. And next, going to the personalized embryo transfer. In recurrent implantation failure, see, normally women have a window period during which the endometrium is receptive to attach the embryo. Usually, it is between 18 to 25th day of the cycle. But for some women, where is a history of recurrent implantation failure, this window period is not between 18 to 25. It is displaced either early or late. So the time deciding the embryo transfer, we are putting the period is already closed or it is yet to open. So what we do is we do a personalized embryo transfer. So we do a test called endometrial receptivity array. It's a test to decide to test whether the endometrium is receptive for the embryo or not. Personalized embryo transfer performed on the day designated by the ERA. There is a 50% pregnancy rate and 38% pregnancy rate. And implantation rate. But it is done only oocyte. If it has failed, then that patient should be tested for the endometrial receptivity. So now going to the take-home message about recurrent implantation failure. It's a really frustrating condition for the doctor as well as for the patient. When there is a good quality embryo put into a good endometrium and it doesn't implant, then if there is a repeated failures, we need to find out where is the problem. So the doctor has to look at the previous histories and find out if she can find a correctable cause for the failures. Many known and unknown causes of RIF, and we do have the tools to diagnose in each case most of the time. Uterine factors, like I said, polyps, adhesions, chronic endometritis, fibroid, or a septum, or a micropolyps, all these can be corrected. All these, or a hydrosalpinx, or endometrial receptivity, as I said, these tests all can be done, and these problems can be overcome. Hysteroscopy, as I said, definitely improves the chances before you plan the next embryo transfer. And the endometrial injury, as I said, in the luteal phase of the previous cycle, or if it's a thin endometrium, we give the adjuvants to improve the endometrial thickness, like we give aspirin, sildenafil, L-arginine, nitric oxide. We give pentoxifylline, vitamin E, GCSF, stem cells, and planning the embryo transfer. If it doesn't work with day 3, then day 5 or a day 4 transfer, assisted hatching, or if there is a hydrosalpinx or fluid in the cavity, and look for hydrosalping and clipping the hydrosalpinx. But very confirmatory evidence doesn't exist for giving aspirin or intravenous immunoglobulin or intralipid. Co-culture, sildenafil, transferring multiple number of embryos, all these are not evident based. Now going to the questions. How many embryos can be implanted in one cycle? See, the number of embryos implanted depends on many factors. What was transferred in the previous cycle, the age of the patient, how good quality embryos we have, and how good is the endometrium. If it's a blastocyst, then even single embryo gives good result. And if it's a day 3 or a day 4 means we do two embryo transfers. Can obesity and stress cause recurrent implantation failure? Obesity definitely has an impact on sperm as well as the oocyte quality, and definitely it can lead to implantation failure. Stress, of course, is not a direct cause causing the implantation failure, but yes, it does has an impact. How many implantation cycle is suggested after 3 repeated implantation failures? How many implantation cycle is suggested? After, see, we define implantation failure after failed embryo transfers. So the probability to pregnancy is only with the day 3 embryo, it's only 25% to 30% in a cycle, in one cycle. On an average, people have to do 2 to 2.5 cycle IVF to achieve pregnancy. Few achieve pregnancy in one cycle, few might require second cycle or a third cycle. So, but even after transferring good quality embryos in 3 cycles, or an average total 10 embryos you have transferred in 3 cycles, and even then patient has not conceived, that patient is called recurrent implantation failure. What care should we take to ensure implantation success? Implantation success. See, implantation success is a very complex thing which depends upon the, from the patient side, you can maintain an ideal BMI, maintain an ideal weight, healthy diet, exercise, and taking the medications regularly. All this can be done from the patient side. From the doctor side, depends on, as I said, looking for any uterine factors, embryo quality, endometrial receptivity, all that can improve the implantation success. Mainly depends on 3 factors. One is the gamete quality, second the uterine factors, then the endometrial receptivity. You can conclude the session with concluding messages. So recurrent implantation failure has to be properly investigated before planning the next cycle IVF. The patient has to be counseled about further advanced investigation, which has to be done. As I said, if it is just the uterine factors, check the endometrial receptivity, or if there is a problem with the gamete, look at the karyotype of the couple, or if you have a doubt about the uterine cavity, you can do a hysteroscopy, check out the issues. So before blindly starting the next cycle IVF, we have to look out for other causes like acquired or congenital thrombophilias, other autoimmune diseases associated with the failure, any immunological causes to be addressed. Thank you.
Thank you, ma'am. Thank you for the wonderful session. I will end the broadcast now. It was
Yeah,
really very informative. Thank you. Thank you so much.
thank you.